Well, first of all, thank you so much for inviting me to talk about this fantastic topic, blood pressure and glaucoma. These are my financial disclosures. None of them have a relationship with this topic. Well, we all know that glaucoma is a multifactorial disease. Of course, intraocular pressure is the most important risk factor, but there are other risk factors associated with glaucoma, including genetics, including blood flow, including neuroprotection. We're going to be discussing something about blood flow and its importance regarding glaucoma. There have been several instruments and devices that were designed to measure blood flow in the eye: color Doppler imaging, scanning laser ophthalmoscopy, the Heidelberg retinal flowmetry, LDV, the dynamography, the blue field entoptic simulation, laser speckle flowmetry, and pulsatile ocular blood flow. All of them measure different vascular beds. So the HRF and the LDF can measure the retinal circulation. The ICG and the scanning laser ophthalmoscope can measure the choroidal circulation. Color Doppler imaging can measure the retrobulbar circulation, and several different devices measure different vascular beds. However, all these devices are expensive. As I said, they measure blood flow in different vascular beds. However, it's unclear which is the most relevant vascular bed we have. All of them are examiner dependent. So the consequence of this is that those devices are now used as research tools, and its clinical usefulness is questionable. Well, this is why we ended up looking for another parameter that could indirectly indicate what's happening to the ocular blood flow, and that is perfusion pressure. Perfusion pressure is defined as the difference between the arterial pressure and the venous pressure in any organ. In the case of the ocular perfusion pressure, we can define it as the difference between the ophthalmic arterial pressure and intraocular pressure. Based on this, we have the mean arterial blood pressure, perfusion pressure, we have the systolic ocular perfusion pressure, and the diastolic ocular perfusion pressure, which can be defined, for example, as the difference between the diastolic blood pressure and the intraocular pressure. Several studies have shown that the diastolic perfusion pressure is a risk factor associated with glaucoma. This was the first study to show that, the Baltimore Eye Survey, showing that diastolic perfusion pressure lower than 30 were associated with an increase in the risk of glaucoma, 6-time increase in the risk of glaucoma. Other studies have also demonstrated that. The Agna-Nurmark study done in Italy, the Proyecto Verde done in the US, all of them show that when you decrease diastolic perfusion pressure, you increase the chances of developing glaucoma. Also, the ocular perfusion pressure is associated not only with the prevalence of glaucoma, but also with the incidence of glaucoma. The Barbados Eye Study has demonstrated a 4.4% incidence of glaucoma after 9 years. And as risk factors, both the low diastolic perfusion pressure, low systolic perfusion pressure, and low mean perfusion pressure were all associated with a higher incidence of glaucoma in this study. Also, ocular perfusion pressure has been shown to be associated with glaucoma progression. This Korean study, for example, analyzed 101 eyes with normal tension glaucoma and identified that 24-hour mean ocular perfusion pressure fluctuation was an important risk factor for glaucoma progression. Now, the main question that is related to perfusion pressure is this: are these findings exclusively due to intraocular pressure, since intraocular pressure is part of the definition of perfusion pressure, or is there any relationship with blood pressure? Does blood pressure play a role? Is there a relationship between blood pressure and intraocular pressure? And yes, several studies in the literature have shown that an increase in systolic blood pressure is associated with 0.2 to 0.44 increases in intraocular pressure. And also, an increase of 10 millimeters of mercury in diastolic blood pressure is associated with zero point 0.4 to 0.85 millimeters of mercury in intraocular pressure. So there is a direct relationship between blood pressure and intraocular pressure. We also know that the behavior of blood pressure varies during the day. We all know that during the night, there's a physiological decrease in blood pressure, around 10% decrease, something that we call the night dip. 10 to 20% decrease in intraocular pressure, in blood pressure, is considered physiological. There have been studies showing that this nocturnal drop in blood pressure is higher in patients with glaucoma, especially in eyes with normal tension glaucoma, since this description by Harry and colleagues in 1994. Also, in the study that we have shown before, the Korean study, the retrospective study evaluating 101 patients with normal tension glaucoma, also the 24-hour mean arterial pressure fluctuation was a risk factor for glaucoma progression. Finally, in the Thessaloniki eye study, low diastolic ocular perfusion pressure was associated with primary open-angle glaucoma in patients on antihypertensive treatment. There was a 28% higher risk per 10 millimeters lower diastolic ocular perfusion pressure. Now, this does not mean that treating systemic hypertension increases the risk of glaucoma. It simply means that treating systemic hypertension and significantly reducing diastolic ocular perfusion pressure may increase the risk for glaucoma, as we can see here. Now, we did a study a long time ago comparing the behavior of blood pressure and intraocular pressure in 29 primary open-angle glaucoma patients. They were under no anti-glaucoma medications, no systemic hypertension, no blood pressure lowering medication, and compare this to 24 healthy controls also on no systemic hypertension and no blood pressure lowering medication. Interesting findings, as we would expect, the intraocular pressure was significantly higher for patients with glaucoma throughout the day. I just want to show you and isolate one specific hour at 4 o'clock in the morning. There was a 6.8 millimeter difference between patients with glaucoma and the controls. Now, if we look at the 24-hour diastolic blood pressure in these same patients, you'll see that at 4 o'clock in the morning, there's a decrease in diastolic blood pressure in patients with glaucoma of 4.2 millimeters of mercury. And when we calculate the diastolic perfusion pressure for these patients, we can see that there is a significant decrease in diastolic perfusion pressure in glaucoma patients compared to controls, starting at 8 p.m. and going through the night, especially at 4 o'clock in the morning when this difference reaches 11 millimeters of mercury. This study is interesting because it shows that the difference in ocular perfusion pressure at 4 o'clock in the morning was not only a result of different intraocular pressure, but also a result of a lower diastolic blood pressure in glaucomatous eyes. In another study that was an interesting study by Charleston and colleagues, prospective longitudinal 85 normal tension glaucoma patients with at least 5 visual fields. They had the blood pressure monitored every 30 minutes for 48 hours at baseline, 6 and 12 months, and 26 eyes progressed during previous follow-up. Now, when they compared those eyes that progressed to the other eyes, they saw that the total time that the mean arterial pressure during the sleep was 10 millimeters of mercury below daytime mean arterial blood pressure, this was a significant risk for progression. So if you have, during the night, a mean arterial pressure that is 10 millimeter of mercury below the mean arterial pressure during the daytime, this may be also a risk factor for progression. So again, low blood pressure associated with glaucoma here. Now I want to show you in this more recent study that we performed along with Alessandro Jamal and the group of Felipe Medeiros. now in the Bascom Palmer, but this study was done when he was back in Duke. This study included 7,500 eyes of 3,976 patients with glaucoma or glaucoma suspect. The data was obtained from the Duke Glaucoma Registry. We employed linear mixed models to investigate the effects of blood pressure on the rates of retinal nerve fiber layer loss in glaucoma. For this, there were 157,000 visits to measure blood pressure, 45,000 visits to measure intraocular pressure, and 30,000 visits to have the OCT done. We found out that the mean rate of retinal nerve fiber layer loss was minus 0.7 micrometers per year. And we also saw that each 10 millimeters of mercury less in mean blood pressure and diastolic blood pressure were associated with faster loss of the retinal nerve fiber layer. Now, this graphic shows this very nicely. You can see here the hotter tones. The red color shows a faster rate of retinal nerve fiber layer loss, and the green color shows lower rates of retinal nerve fiber layer loss. And what you can see here in this example, for example, patients with high intraocular pressure and low mean arterial blood pressure have a faster rate of retinal nerve fiber layer loss. Whereas this patient here, on the other end, with higher mean blood pressures and lower intraocular pressures, have a lower rate of retinal nerve fiber layer loss. So this, for me, shows brilliantly the important relationship between intraocular pressure and blood pressure. Something that was already shown a long time ago in 2009 in an experimental study here in primates. The group of George Chaffee, they observed the perfusion of the optic nerve with laser speculophotometry with an increase in intraocular pressure with a normal blood pressure of 102, showing that there's mainly no change in blood flow because of autoregulation. When you do this, the same thing, increase intraocular pressure to 30, and you decrease blood pressure to 70, you have an important decrease in blood flow. And finally, when you decrease the mean blood pressure further to 56 millimeters of mercury, you can see the important drop in optic nerve blood flow, because in this situation, autoregulation was not effective to bring back blood flow to the normal situation. What is the problem we're having right now? There's an intense relationship between glaucoma and systemic hypertension. There's an increase in life expectancy, so that will lead to an increase in glaucoma prevalence and also an association with systemic diseases, including systemic hypertension. In 2018, there were approximately 500,000 patients with glaucoma and systemic hypertension in the United States. In 2030, this number is supposed to increase to 880,000. And finally, in 2050, this number will increase to 1,300,000 people with both glaucoma and systemic hypertension. The problem is that there's a tendency to treat systemic hypertension more aggressively. In this study, the systolic blood pressure intervention trials, a SPRINT, there was a group treated aggressively with a target systolic blood pressure of 120 versus a conservative treatment group which had a target systolic blood pressure of 140. What they saw was that significantly lower incidence of cardiovascular endpoints in the aggressive treatment group. However, there was a higher incidence of serious adverse effects like syncopes, hypotension, acute kidney injury. Also, the American College of Cardiology now suggests that systolic blood pressure should always be below 130 and diastolic blood pressure below 80. I have no doubts that the consequences of this more aggressive treatment towards systemic hypertension will increase the number of significant dippers at night. This will decrease the diastolic ocular perfusion pressure and probably will increase glaucoma progression. What we suggest for patients with glaucoma and systemic hypertension is that those patients should be carefully monitored sometimes with 24-hour blood pressure measurements. We should have a close contact with the cardiologist or the general practitioner in order to achieve a target blood pressure and a target intraocular pressure that would inhibit both cardiovascular events and glaucoma progression. We should never forget, and we should always face a glaucoma patient as an individual and not as an optic nerve within the eye. Ophthalmologists need to ask patients about their comorbidities and their treatment, including systemic hypertension. Ophthalmologists need to be aware of all the possible interactions between comorbidities and glaucoma and adjust the treatment accordingly. Multidisciplinary management of such patients is highly advised. Again, thank you so much for inviting me to be here. It was really a pleasure. Again, thank you, Natalia and Russia, for having me in this meeting.